So I've been in practice for about 20 years, and I'm an advanced endoscopist by trade, so I do a lot of advanced endoscopy, but my focus clinically and in research has been in Barrett's esophagus. I currently serve as Associate Chief of the Division of Gastroenterology and Hepatology at Northwestern. My interest in Barrett's has stemmed from a lot of the work that I do around education and innovation, and it's an exciting area in our field right now. I also serve as the chair for the Center for GI Innovation and Technology for the AGA, or American Gastroenterological Association. And as part of that, we most recently put forth a clinical practice update from a consensus conference that really highlights some of these novel innovations that we've seen in screening and surveillance for Barrett's. Yeah, it's a very exciting time for gastroenterologists managing this disease. For the last 20 years, we've been very focused on modalities for treatment like radiofrequency ablation and resection techniques. And what we found is after that time period is that we are very good at eradicating this disease, but we made no change in the incidence of esophageal adenocarcinoma. And so when you look at this data, it really comes down to the number of patients that we're seeing who are getting screened, who are getting evaluated and surveyed, and that denominator is very small, and we have studies that have shown that previously. And the nice part about it is that with the clinical practice update and some of the novel innovation that has come forth, we can increase this denominator in multiple fashions, not only the entire pool through screening techniques, but also utilizing a technology like TissueCypher for risk stratification of this large and growing population of non-dysplastic Barrett's. To start off, I think there's been a lack of understanding of what progression is with non-dysplastic Barrett's because we haven't had the tools. And also, when you're dealing with a small denominator, you don't see a lot of progressors. But people are still getting cancer, so people are progressing. So we've used clinical parameters, some of the basic ones like age over 50 or male gender or smoking or central obesity, and some of these things are very almost too encompassing, as you can imagine. And so as such, the data shows they don't really bear out as great tools because you're going to have a very large population of patients you're going to screen. So in terms of the patients we know that have Barrett's, once they have a diagnosis and have non-dysplastic Barrett's, it becomes very challenging. And I think as gastroenterologists, we're used to very objective measures to guide us in what we do in terms of decision making. And we haven't had that to date. So some of the subjectivity has basically left most of these non-dysplastic patients untreated, at least in the ones we know about now. And I think we've done okay because the denominator has been small. But as we move forward and increase that denominator, we're going to see patients, if not treated, who are going to develop adenocarcinoma. I think it's a great example of innovation going through a process in terms of not only technology development, iterations over time, but also evidence that is required to really push the needle forward in an area that's been sort of quiet. And I think all of the many studies, starting with just simply showing the value of the assay in terms of its scoring system and validation of what that means for patients who have a high risk score, looking at studies around how this is affected by the length of Barrett's in terms of spatial analysis, and then over time as we survey patients, the value of the tool. And then finally, most recently, a lot of the data really showing how all these studies come together and give us a objective sort of measure that can help us identify which of our non-dysplastic Barrett's may develop cancer at a fairly high rate. So I think this data and process has come together to actually give us that tool I spoke of that objectively now gives us a parameter to sort of separate those patients who have non-dysplastic Barrett's who might benefit from endoscopic eradication therapy. we see patients with indefinite for dysplasia and low-grade dysplasia. We do, in those scenarios, want to optimize some things like reflux management. Some of those kind of disappear. But we do know, and not only the data from TissueCypher, but other data has shown that when pathologists look at this, there's a subset that are undercalled and a subset that are overcalled, and this may represent non-dysplastic Barrett's or it may represent high-grade dysplasia. So what that's left us with is a problematic situation where you have two options. One is you could just treat everybody, but then again, going back to what I said is as physicians, we want an objective parameter to make decisions. That doesn't really fit that parameter. Or is there a tool that helps us clean that up? Is there a tool that kind of gives us an idea of better than the pathologist? And I only say that because we know that the best pathologists disagree on these diagnoses at a high rate, right? They have a lot of intra-observer variability. So a technology like TissueCypher and the data that has come forth from Amsterdam and other places has shown us that's exactly, and we see this in the pooled analysis, that what it can do for patients with low-grade dysplasia is really identify that pure population that would most benefit from treatment and help us sort of be that pathologist's aid, right? How do the sort of concept of augmented intelligence, the pathologist plus the computer, gives us the best sort of outcome to then objectively take action. I think, as we move forward, it's essential for us as physicians to understand this is a continuum of disease. So you're not a Barrett's physician, you're not a reflux physician, and so when you look at this, it's all the way from our primary cares to our surgeons, right? It's reflux that's not symptomatic, but that reflux causing inflammation or esophagitis, causing Barrett's, causing neoplasia, causing cancer is all one path. And it all goes down the same pathway. So as physicians, we need to be invested in that pathway. And one of the things we're doing at Northwestern is, especially with the latest clinical practice update, opening the door for thoughtful screening of patients now without reflux, is we want to create an environment where patients can be evaluated, studied, and looked at to understand the value of this, because ultimately our goal is the reduction of esophageal adenocarcinoma. We have the ability to get there, but we need to use environments like this. And this clinic will allow us to screen more patients, to identify more neoplasia, also identify a lot more patients with Barrett's. And then using that, we need to use some of the tools like TissueCypher to take action. Because again, if we identify a tenfold number of non-dysplastic Barrett's, we're going to have some cancers that are going to arise from that. And the worst thing would be to identify a lot more of those patients and not have a plan of risk stratification. As we discussed, they're definitively for some of these confusing patients with indefinite for dysplasia, maybe some of the low-grade dysplasia that maybe there's a disagreement. We're going to have some discordance between an expert pathologist and someone else, and this is a great tool to sort of break the tie. But for us, I think the impact will be in the non-dysplastic population. And I think we'll start with a subset of risk factors that we'll see kind of outlined by this CPU, this clinical practice update. And then I think it's going to get to a point where we're just really probably going to have to apply this on a more generalized fashion to patients with Barrett's in general. If the impact continues to be as we've seen it, I think it's going to apply to almost all of our patients with non-dysplastic Barrett's. I think there's two things. One, there's no reason what I'm saying, from the clinical practice side, it was what we've been talking about. There's no difference between me doing it or my colleague out in community practice. And in fact, as a system, Northwestern, we now work with many of our community partners, and whether it's purely on the clinical pathway or research, we will advocate for the same thing across our system that we do, they should be doing as well. So, and again, a community practice is going to see the most Barrett's, probably over an expert center. So that's based on what we've talked about and the importance of the tool. It's going to become probably even more important for them to be involved with this technology. The major focus was again, where is our largest gap and where do we make an impact? If we're going to make a statement, where can we make that statement? I think, and that focus was in this large population of non-dysplastic Barrett's patients. So, and then when we're making, again, a clinical practice update is, not a guideline, and there's a lot of nuances there. So we want to be thoughtful about how the statement comes out. But the purpose of this was we have new innovation that has it's been very validated and is ready for prime time. So we need to create a statement that allows it to be used in practice. And I think that was the purpose of this, to say that this is something that should be considered for your patients as a practicing gastroenterologist in patients with non-dysplastic Barrett's. Now, how we do that is something that we take that ability to do it now, and we work as a community of physicians, and we better understand those populations and where does it have the most impact. Is there some clinical risk profile within non-dysplastic Barrett's that would most benefit? And honestly, we need to study it more. We got to get more clinicians using the assay in their practice to better understand where the value is going to be. But I think the clinical practice update has recognized the investment and the time put into this innovation. It's recognized the data and the quality of the data to open that door finally for us to actually utilize this clinically and identify where it best fits in the long term. Yeah, I think the initial, as we start off on this, and by start off I mean on a more widespread clinical utility based on this, I think there's two things. One, the knee-jerk reaction is that's concerning. We're doing this test to identify that subset. And so for sure, what this would prompt is a discussion with the patient and I think this is going to be important. I think as we really disseminate TissueCypher, we want this, as any new technology that becomes more disseminated, we want this to be a very transparent discussion with the patients, so they kind of understand that what's happening and what this means and how this, because for them it's like, well, my biopsy looks fine. So we want to explain that to them and with the data, and I suspect most patients would want to be proactive about this. And I think, again, we've been treating patients without dysplasia for some time, but not with any thought. So this becomes a pretty easy answer, in that this is somebody we'd offer endoscopic therapy. There probably are some other things in terms of reduction and extension of intervals based on this technology. So whether it's, looking at that 3 to 5 year span and dropping down to 3, or taking someone from 3 to something shorter than that, I think that's a possibility. I personally would think that if you're going to go less than 3, maybe treatment is going to be the best option. But I do think there's the other side where patients may be a risk of 1 or really low risk. Where we may say you're at the 5 instead of 3, or maybe we're going to stop. You're 7 years old. We don't need to do this. So I think, again, but these are things we want to get more clinical experience with to make some more definitive statements. Anything that ultimately helps our diagnosis in terms of accuracy, helps us learn and helps us understand what we're doing. I think the high quality exam of what we're doing, again, goes back to this. There's some people waiting for AI to come in and just do the exam for us. I don't think that's going to be the case here. I think it's going to help us achieve this high quality exam. So inspection, identification of neoplasia. So what happens is you have a scenario where we can become better at identifying things that are obvious or should be obvious. But we know there's a whole subset of patients where there will be no visible lesions. And we're going to have more and more of those patients that, despite a high-quality exam, still have non-dysplastic Barrett's, but they have aggressive disease. And I think it's impossible to do that with an endoscope, honestly, at this point. So we need that adjunctive technology. The center was put forth to really facilitate and help the relationship between practicing gastroenterologists, industry, and other stakeholders in terms of advancement of really innovation all the way through adoption. And I think whether that's working with a startup or a large corporate partner in terms of things like clinical trial design, all the way through sort of, how do we best adopt this? Which patients do we use these types of technologies in? The goal is to really bridge the gap that delays innovation, making an impact for our patients. And I think the work we've done with TissueCypher, for example, is a great example of focusing resources into the right studies, and we've seen those come to fruition. And we've now ended up with a technology that's ready for adoption. And I think that's a success for us. And I think if anything that we can put through that pathway is what makes CGIT really tick and make it successful across the board. Traditionally, clinical practice updates have been just an expert opinion of a few people. We felt that when we're talking more about innovation like this, which is very novel, we wanted a more diverse opinion. And I think that diversity stems across countries, it stems across gender, it stems across practice type. And we did have community doctors represented on this panel. And obviously, we included our industry partners across the board. We included people, who look at regulatory aspects of this, like the FDA, and patient advocates, people who understand this disease and the impact it has on their family. So again, having that diversity is what makes this a unique sort of project, and it's not just a couple of experts sort of opining their own opinions. Again, this is when you talk about consensus and Delphi processes, it does come down to expert opinion in the end. But when you have a diverse, large panel of experts across the world, it becomes a lot of the evidence translates into that. So we review the evidence, we discuss it, and then ultimately we take a vote on what statements would be appropriate and are ready for sort of bringing to our physicians in terms of this practice update, and then obviously how we word it and the way we make that statement ultimately as well. So again, a consensus, for lack of better words.